Welcome to the Gynarchy Podcast. This is your host, Dr. Gynarchy Patel. Here we place women's health and feminism front and center where they belong, engaging in conversations that range from the fundamental to the fearless. With insights from expert guests, we aim to break through the barriers of the patriarchy and envision a new world led by the Gynarchy. So let's get started and dive right in. Welcome to the Gynarchy Podcast. This is your host, Dr. Gynarchy Patel. And today we're going to be talking about probably my most important topic for this season, attacks on birth control and abortion. And I have a wonderful guest today, Dr. Diane Horvath, who is a double board certified OBGYN and complex family planning physician. She has a master's degree in public health and has also trained in patient advocacy with Physicians for Reproductive Health and is co-founder and medical director of Partners in Abortion Care in College Park, Maryland. Did I get that right? Thank you so much for joining me on this podcast. Really excited to talk to you about this. It's an election year, and this is just the topic I am obsessed with. We need to fix this. So tell my audience about yourself, a little bit about yourself, your background, and what you do now.
I am a Midwesterner, so I grew up in Ohio and Wisconsin and Minnesota, and I kind of always knew that I wanted to be a physician. My dad is an internal medicine physician. He's retired now, but I grew up kind of never really considering another job. And I made my way through medical school and realized that I enjoyed reproductive health. I enjoyed taking care of women, and I really enjoyed doing procedures and surgeries. And so OBGYN just made the most sense to me. And I practiced as a generalist OBGYN for about 4 years in St. Paul, Minnesota. Really enjoyed that job, but realized that the best part of my job was the time I actually spent at Planned Parenthood, taking care of folks who needed abortions. And it occurred to me after a couple of years of being in generalist practice that people are always going to want to do C-sections in the middle of the night. There are always going to be people who want to do hysterectomies, but that if we didn't have more people trained to do abortion procedures, particularly later abortion, that we might not have that service protected into the future. And so I really enjoyed it. I knew that I was good at teaching. I was working in a teaching position. And I thought, I think I just really want to make this my job. And I actually, when I talked to my department chair at my hospital, I felt kind of bad because I really liked the job. And I said, I just want to let you know I'm going to be applying for a family planning fellowship. And he said, I knew you had itchy feet. I knew this is where you're going to end up. So I think I wasn't very good at keeping it a secret, but I did a fellowship in family planning at Washington Hospital Center in DC. And that was what brought me to the East Coast. And I fully intended to stay or to, do my 2 years and then go back to Minnesota. But things being how they are, this ended up being a better place for me to be. And I've been working in a bunch of clinics since then. I've worked in probably a dozen different clinics in this area and also in the Midwest. And I was actually traveling to Alabama for a period of time prior to the Dobbs decision. And that obviously stopped. Alabama had a trigger ban that went into effect the minute the Dobbs decision.
Is that one of the states with the total ban?
The full ban.
Yeah. Wow.
So that the folks in those states lost abortion access literally overnight. And that was when they didn't have a need for me after that. So I stopped traveling after that. But I decided after working in a bunch of different places that I really wanted to have my own practice. And my business partner is a certified nurse midwife. And she and I had been talking for years about having our own clinic and doing things in the ways that we had learned that were really, good things we had taken from other jobs and things we had decided to leave at other jobs. And so we started seeing patients in October 2023. So we ended up, we planned the clinic prior to the Dobbs decision leaking, but we kind of knew that Maryland is a very supportive state for abortion access. And we just kind of knew that those oral arguments had already happened. They were not great. And this is, the Dobbs decision and the overturn of Roe is part of a 50-year strategy by anti-abortion activists. And so this was coming down the pike for a long time. And so, we just thought now is the time, there's never going to be a better time to have another clinic in a supportive state that specifically takes care of patients who need abortions later in pregnancy. So that's kind of how I got here. That's the meandering story. But
Wonderful. I mean, I'm grateful for doctors like you. One of the things about OBGYN that has changed over the years that I've seen, I was trained in abortion care, of course, during my residency in New York. But over the years, it's kind of parted ways with regular OBGYN practice, and it's been outsourced to Planned Parenthood a lot. So I haven't done an abortion myself. I've done D&Cs, which is pretty much done in a similar way, but not with the vacuum, for example, in decades. And so there's a part of me that feels like, oh, this is horrible. I've become unskilled in this. I'm sort of tempted sometimes to go back. I mean, life is long. I may do that because the need is there, and we need it, especially now. So it's become divorced from traditional OBGYN practice. And now there's centers for just abortion care, and those are being shut down. And the doctors now that are practicing do not have the skills to provide this or set up shop like you've done. So that's something that has to change, isn't it? Like, we need more doctors like you.
There's a lot of OBGYNs and family physicians and emergency department physicians and pediatricians, and also certified nurse midwives, nurse practitioners, physician assistants. We have really good data to show that folks, non-physician clinicians, so advanced practice clinicians, can provide abortion care safely and effectively. And certainly there's parts of the country where it's a doctor shortage in general, and it's no different for abortion care. But there's lots of people who want to do this, lots of people who need training. But unfortunately, a lot of hospitals and other practices have a lot of restrictions on abortion provision, even in supportive states. I have a lot of colleagues that would be very happy to provide abortion care as part of their generalist OBGYN practice, but they're prohibited from doing so by hospital or clinic policy. I think the other thing that's important to note is that abortion is a very low risk procedure. And so it really doesn't actually need to be in the hospital most of the time. And so, I think we would love if more hospitals provided this care, because some patients are too ill to have an abortion in an outpatient facility, and they really need hospital care. But most abortions are super low risk. They're the same level of risk as dental work. And so they can and should be provided in a clinic. And it's too bad that a lot of that's been so siloed in some ways that you have to go to a clinic that specifically does abortions. You can't just go to your own doctor or nurses or whatever's clinic. And that's caused some problems. But on the other hand, the care is really efficiently provided in these spaces.
Mm-hmm. I mean, this sounds like in these times where they're trying to restrict care, maybe more of these clinics should be set up. I'm really interested in what you just said about other types of providers being able to safely provide abortion care. I have not met any where I'm at. It's all OBGYNs, but do you mean medical abortion or surgical abortion, or both? I mean
both. So we actually, my business partner is a certified nurse midwife, and we also employ a full-time nurse practitioner as our nursing director. And they both actually provide procedural abortion in the first trimester. So, medication abortion, there is absolutely no reason why medication abortion can't be provided by a whole range of clinical care providers. And certainly early abortion, the studies that looked at safety looked at abortion in the first trimester, and the complication rate was so exceedingly low for both physician and then advanced practice clinician providers. And so I think the key is training. And there's the issue that there's so few places to be trained. Physicians, we hope, get training in residency, but we know that that's not the case everywhere. And we know now in these banned states, even OBGYN residents who are supposed to be given this training, it's supposed to be built into the curriculum, are having to travel out of state. And legislatures have been working to try to even restrict that ability and denying funds to these programs that set up these out-of-state rotations for OBGYN residents. So you can imagine if OBGYN residents can't even get this training, how hard it would be to get this training as a nurse practitioner. It's just not available.
Right.
One of the things provide it as part of our practice. So we do take learners in our practice.
That was going to be my next question. Like, how does someone who listens to this podcast, who's maybe a general practitioner that wants to help, get this training? So, you reach out to clinics like yours, I guess, and do you know other avenues?
Yeah, so Medical Students for Choice actually provides funding and support for both medical students, but also resident physicians to get this training if their program doesn't provide it. So that's one place to go. Another organization called the Midwest Access Project provides funding and like administrative and logistical support to get people, including clinicians out in practice. We actually have a midwife who works with us a few hours a month who trained with us through the Midwest Access Project. And now she's one of our clinicians, which is great. And it's certainly not enough spots, but it's available. I think it is really hard for places who are busy and running on a shoestring budget to take learners because it costs time and money. We love it, but it takes extra time. And we're slower when we have learners, and that's completely okay. And I've always enjoyed teaching, but it makes the day go longer. And so that's staff time that has to be covered. There's all kinds of other administrative things that have to happen, like getting people's licensing together and making sure that they're covered under liability policy and things like that. So groups like MSFC and Midwest Access help with that type of support. So that is where I would recommend people go, is to look for organizations like that help make that process really streamlined for clinics.
Okay, wonderful. Now you said we know you're in Maryland, and my impression that abortion is pretty much legal with few restrictions there. Is that correct? Do you have any restrictions?
We have a parental notification law, so a mandatory parental involvement law that requires one parent notification. But the way that it's constructed is such that a clinician can waive the requirement if we determine that a minor is mature enough to make the decision about an abortion. And my feeling on it is, if you're mature enough to know that you don't want a parent, then you're mature enough to decide to have an abortion. So, I think the issue is that it creates confusion for young people. And so they think, they're like, oh, I don't know if I'm going to be able to get this abortion, or do I have to go for a judge? So, it is harmful. Like, even though it's fairly easy to waive for us upon assessing this person, it's still something that harms young people. We, fortunately, in the fall, in November, we are going to have a ballot question, a constitutional amendment question on our ballot.
Wonderful.
Which would enshrine the right to reproductive options in our state's constitution. And so that would effectively remove any of these restrictions. And so that would be a huge, we're already a supportive state. We don't actually have a gestational limit in Maryland. We are allowed to have one. The way the law is written, it says that legislators can make a gestational limit, but they haven't. And so we actually don't have a gestational limit in Maryland. We don't have a lot of other onerous things. Clinics are licensed and inspected in the same way as all kinds of other medical clinics. So there's no special carve out for abortion clinics to regulate them in a stricter way. They're regulated as medical facilities. Okay. So it's a good place to practice. It's a good place to live. We are in a very supportive community where, city leaders and law enforcement and our neighbors are all incredibly supportive here, which has been great.
That's wonderful. I know you hear so many barriers elsewhere. So you don't experience any of the harassment that other doctors do? Okay.
I wouldn't say that. There's a particular group, I won't name them, who really just have, our existence troubles them. And so they've protested when we weren't open. So they came on a Saturday, which they just annoyed the dentist's office across the courtyard. And they've also flyered our neighborhood. Before we opened, they flyered our complex and the neighborhood around us. We're very close to the University of Maryland. And so the community here is really progressive. The students, it's a very progressive student body. And the flyers that they put out were gross and very insulting. Community, actually. And so they thought it would make people angry with us. And the result actually was that it made people know we were there. So it was free advertising for us. It also resulted in us getting notes of support from the community. We got offers
donations.
Donations. Yeah, we got monetary donations from our neighbors.
Wonderful.
Yeah. So they tried to, they stuck stickers all over everything, a few months after that. And we had our campus, we've built community with the students on the campus, and our campus partners went around and took all the stickers down. So
I love it. You have just, I love that. You've just inspired an idea. I'm like, you could just counter protest their dumb protests where every place they're at. Like,
I would,
right?
Yeah, I would say make sure, if you do want to counter protest, make sure you talk to the clinic first, because protests are terrifying for patients, and sometimes patients don't know if somebody is a protester or a counter protester. So there are definitely clinics where counter protesters are welcome, but reach out to the clinic first, just so that you're not adding to the chaos.
Okay, thank you for that advice. So that's really wonderful. I was thinking that while you were saying, I was thinking, gosh, in a progressive, like a state like that, they must be angering people around town.
Yeah.
And so this just kind of reminds me of, just what's happened, right? It's so devastating what happened with the Dobbs ruling in 2022. And I think after that, just, you just felt like, I still feel just devastated by that ruling. But it's been kind of a mixed bag of what's happened. There's horrific cases almost every week in the media, which make me just so mad, about the women going through this and having to publicly do this and file lawsuits in their states, right? But weirdly, it's also just triggered this wave of feminism like the 60s, I think. This must be how angry they felt, because that's how I feel. I just want to pop off every day. I'm just so angry. And, it's like you really can't. They've also started this counter movement, and states like yours, for example, so many states have these ballot measures now and are trying to enshrine it in their state constitutions. So while there's a bunch of states trying to restrict abortion even more, there's a bunch of other states trying to expand it. And so while there's been an increase in childbirths, right, in states with increased bans, there's also been an increase in abortions, I read. So,
yeah, it's just such a really good example of like banning abortion doesn't make it happen less. And, if you look globally, the places that have the fewest abortions, and I just want to be clear, like my goal is not fewer abortions. My goal is as many abortions as people need. But there are a lot of people who have abortions that would have preferred to prevent a pregnancy, right? Like they would love to have had access to good birth control. And we know from just looking at countries around the world who have very liberal abortion laws, they also have really great access to birth control, and they have far fewer abortions because people get better sex education. They get, birth control that is covered by their, government sponsored insurance. Like there's all of these things lined up. So the health of people is never good in these places that ban abortion, because it's part of the strategy to basically just like marginalize and harm like poor and Black and brown and young people. Like it's, big, strong, nasty abortion laws go hand in hand with lack of access to healthcare.
Yes, that's the other thing. Women are still getting abortions. There was a slight overall uptick in 2023. It's just the ones who are getting it are the ones who are able to travel, have means, basically money, right? So it's disproportionately affecting, right, low income, Black, Hispanic, and Indigenous people, and causing higher birth rates with them and struggles for life, right? Sometimes. And these same states, of course, also don't have very good support for families with children.
And also worse perinatal mortality. So like maternal mortality rates are high in the states that have abortion bans. Pregnancy is a more risky condition than an abortion. So, and it's not to say that people shouldn't get pregnant for babies, but we know that abortion at any point in the pregnancy is safer than continuing a pregnancy and having a birth, particularly if you are in a place where you are at high risk for bad birth outcomes. We know that racism is a cause for bad birth outcomes, and like they just racism lines right up with abortion bans. Like it's all happening in the same places to the same groups of people. And I think it's also really important to recognize that abortion is very popular with the voting public. So if you look at all the states that have put referenda on their ballots where they pulled abortion out from all of these other issues, they took it away from political affiliation. It's not just one party supporting it. People vote for abortion every single time.
Right.
So I think that these ballot initiatives and constitutional amendments are a great strategy. Overall, I think this is showing that people on both sides of the aisle recognize that folks need to be able to make their own healthcare decisions without the involvement and interference of the government.
Yes, I think the last statistic I read was 63% of Americans support abortion overall. And right, like what you're saying, even in the red states, when it's put on the ballot, then it ends up being that the public supports abortion. So that is an excellent strategy to counter what they're doing. So yes, and this week, speaking of birth control, it does strike me as disingenuous that they're trying to cut down on abortion rates, because why not support birth control then? What is that about? What is going on with the Republicans not voting for more access to birth control this week at the Senate,
And one, I think as a reasonable person, you would look at this and say, wow, if you are against abortion, wouldn't you be pro-birth control? Because we know from like reams and reams of studies that access to good birth control decreases abortion rates. So if your goal is to decrease abortion, then cool, you would be for it. And there are some people who are pragmatists about it, who are uncomfortable with abortion and support access to birth control. Those people have not been elected in many of these states. Like that pragmatic position is not that's represented in the legislature, unfortunately, because of voter suppression and gerrymandering and all of these other things.
Right.
The issue, though, I think this needs to be said, is that these people are not just against abortion. They are against people being able to make decisions about their own health and their own sexuality and their own lives. These are the same people who are banning gender-affirming care. And not just for kids, but for adults. Like these people are not into you being able to make decisions about your own body. So like birth control, decisions about birth and about pregnancy, just in general, these are the same folks who want to criminalize things like drug use and pregnancy, even though we know that addiction is a disease and prison time is not the answer. It's access to treatment, but they want to criminalize people for their pregnancy outcomes related to drugs and alcohol. Sometimes criminalize people for pregnancy outcomes unrelated to anything that person did. So like, this is all part of a larger kind of feeling that like your body is not your own and that the people to make decisions about health and bodies and healthcare and sexuality are old white men. And like this is a white supremacist strategy to increase the number of births among white people and to basically make it so that Black and brown folks are systematically disadvantaged and kept out of, being able to participate fully in community. So like this, I think when you see it that way and you start to see all those connections, it makes a lot of sense.
That really does make a lot of sense. It's about power and control. And I think you're spot on about the white supremacist nature of that movement. And actually, something else you said reminded me of, another thing they do besides not wanting to support birth control. They also, the sex ed is so lacking in these states as well. There's a lot of abstinence only education, which is so ridiculous, so right. Young people not knowing about sexual function and reproduction is going to also increase, unintended pregnancy rates. So
sure. And, we've got now a national explosion in STIs. So the rates of syphilis have gone way up. The rates of all kinds of other STIs are the highest they've been in a long time. And, some STIs are curable. Some are not. And even the ones that you can cure can cause irreparable damage. Like chlamydia and gonorrhea are associated with decreased fertility. And, 80% of the people who have these STIs have no symptoms. That's the most common presentation for STIs is asymptomatic. So sex education, access to screening, all of these things that the people who are against abortion are also trying to remove from people's, hands. It harms people on so many levels. It is such a nefarious kind of strategy to keep people ill, keep people, just like as second-class citizens. So
right. So yeah, I've seen that uptick myself. It's kind of wild to start seeing younger people with syphilis tests that are positive, and gonorrhea has become more normal to see, which I remember 20 years ago, it was like, I never really saw it, So it is, I agree. I think it is, and this is in Massachusetts, where it's just not, so one of these states that is really backwards. So one of the things that really concerns me is these like 6-week bans. Like a lot of patients don't even know that they're pregnant then. And this is so crazy how many states there are with these 6-week bans. I think I looked it up and it's something like 14. I might get that. I might be wrong, but something like that. That's a lot. And the other thing I'm confused about is, where do they pull these numbers out of? 6-week bans, 12 weeks, 15, 20, 22, 24. Viability. What number of weeks is that exactly? Does it? And so what is the logic behind that? Is there any explanation? Do you know?
So the strategy is to eventually ban all abortion. So I think that that's the most important thing to remember, is these are not people who want to compromise. They frame this as like a common sense compromise, like, 15 weeks. And then the next time they pass a bill, it's 12. And then the next time it's 8 or 6. And you're right that a lot of people don't know they're pregnant at 6 weeks. And by the time you get into a clinic that's really busy because it's the only place in your region, maybe, that offers this care, you are beyond the point where they can take care of you. And then you begin this process of having to travel out of state, and it's much more expensive. And then you have to get childcare and job coverage and all that stuff. These are not people who in good faith want to come to a compromise. These bills are pushed by people who want to ban all abortion. And this is just the strategy. If you can start with a viability ban, and I use viability in quotes because I don't think that any of these people could actually tell you what viability means from a medical perspective. And I'm happy to talk about that more, because I think that's a really important concept, because it's coming up with these ballot initiatives. And I think our side is giving ground that we shouldn't be. But these anti-abortion folks will start with viability and say, well, that's common sense. And then they push it down to 15 weeks. In fact, there are people trying to convince legislators and the public that 15 weeks is viable. 15 weeks is never viable under any circumstances. Like, that's totally bananas. That's absolutely not true. But, you keep saying it and you keep talking about how reasonable it is. And eventually people start to think, well, yeah, I mean, that seems like a reasonable compromise. Why would anybody need an abortion after 15 weeks? And I can tell you that people need abortions throughout pregnancies for all kinds of really good reasons. And I think, as somebody who runs a clinic that sees folks later in pregnancy, we go up to 34 weeks of pregnancy. And I certainly hope that none of your listeners ever find themselves in a position where they need an abortion at 34 weeks of pregnancy, because something has gone very badly for these folks. And it's not just fetal anomalies. It's really, really awful life circumstances. I've seen patients whose homes had burned down, midway through the pregnancy, and there wasn't a shelter in town that could take them and all their children. So their kids were split up among relatives, like they lost everything. So like big, big life changes. We know that the most common cause of death related to pregnancy is homicide. Right. So we also know that violence against pregnant people happens more during pregnancy, right? Like you might have a person who's never been violent before, and pregnancy is such a uniquely vulnerable condition to be in that violence rates go up. And we know this, and like your violent partner is more likely to become more violent when you're pregnant. And I trust pregnant people to know when it's not a good time for them to be pregnant anymore. And sometimes you don't know that until later in pregnancy. Sometimes you have a medical problem that doesn't show itself until later in pregnancy and becomes health or life threatening for you. And again, I trust patients to know when the right time is for them to be pregnant or to stay pregnant. I do not trust a legislator to make that decision on behalf of the patient. And I think that people need to ask themselves when we talk about viability bans is at what point in the pregnancy would you give up control of your healthcare decisions to a legislator?
Right.
And I'm not comfortable ever giving up my health decisions to a legislator. And I think this idea that people waltz in off the street at 34 weeks and decide they want an abortion because they're tired of being pregnant, it's bananas. It's not true. We all know it's not true. And it's out there as a right-wing talking point to make everybody feel bad and icky. I don't need people to feel good about abortion later in pregnancy. I don't need you to like it. I don't need you to feel good about it. I don't need you to ever have one yourself, but I need you to understand that you are not better positioned to make decisions about this than the patients are in concert with their healthcare providers. And also a legislator is not in a better position, a decision about this. So I wish we could talk about later abortion in terms of the people who need them, as opposed to having to justify all of the circumstances to the public. Because I promise you, you just don't want to have to. They're hard for people.
I mean, so many thoughts about what you just said. Like the last thought, like these cases that are coming in front of the public every week or every other week or every month, they are highlighting these circumstances. Like, do you see after you hear this case and the details that the decision should be between patient and doctor? Like, I think it is drilling into people's minds, like, oh, well, the baby wasn't going to make it anyway. Oh, well, she, it would risk her life, and it's like, why do we have to explain every damn case and expose these people, publicly? They can't retain their privacy. They have to go to a court to get their exercise their rights to control their own body and what, having babies. And they have to expose themselves to national heat from these pro-lifers to explain a justified need for abortion, and then at the end of the day, a lot of people agree. Most people would agree that yes, she should get an abortion. Give her let her have the abortion. Let the doctor make the decision with her. So that's, I think, super frustrating.
Yeah, it's a really good example of why these bans with exceptions do not work. They are unworkable. So if you look at this case in Texas where they had a whole, more than a dozen plaintiffs, basically with pregnancies that were not going to produce a baby that would survive. So horrible, sad, just really tough cases of people who were devastated to be losing a pregnancy. That should have been a circumstance in which a doctor could have intervened. And the fact that the Texas Supreme Court said that, these didn't qualify. These basically were not a problem with the Texas law. They were a problem with the physicians, which was incredibly insulting, because I have colleagues in Texas that are willing and able and have the expertise to take care of these patients. And they are terrified not only of losing their licenses and their livelihoods and their ability to practice and feed their families and all these things, afraid of going to prison. I mean, Texas has a criminal abortion law. So to act like the doctors should have known that they could take care of these people is preposterous. And these are unworkable laws. Bans with exceptions are bans. They do not practice.
And yes, making this criminal against doctors, this is just, and now they are trying to criminalize the patients as well. But still, it's like it puts us in a very uncomfortable position. I feel so badly for doctors who have to practice in these states. And this is why there's already a doctor shortage nationally in every state for OBGYNs, for women's healthcare. And now these states are no longer drawing, as many new grads, doctors. They're increasing their shortages. And they're becoming these maternal health, women's health deserts. I mean, they're scary places to live as a woman, I wouldn't even want to live there and raise a girl child there.
There was just I think that this is a really good place to point out that there was actually just a study that looked at applicants to OBGYN programs and to residency spots overall. And in states that banned abortion, OBGYN residency applicants were down, I think, more than 7%. And then all applicants. So like even people who are not in fields where they do abortions or train for abortions, people don't want to practice in a state that treats health providers in that way. And actually, there was just another article that looked at, I think it was Missouri, who passed an abortion ban, and OBGYN applications to the programs in Missouri were down over 20%. So like, that's a problem. We have places where like you can't even get in to see an OBGYN because there's nobody in your region who does it. And like, I think, this is going to result in more harm to pregnant people. And I think like I think it's good that like we have a lot of our care can be managed concurrently with like a midwife or a nurse practitioner, but like midwives and nurse practitioners don't want to practice in these states either.
No, there's like mass exodus. People are looking not to work there, and people who are established and already working there are trying to leave. And it is good what you pointed out. You're right. Would I want to be an emergency doctor in one of these states? No. Would I want to be an internist and admitting patients with sepsis who have incomplete, who need to have a DNC, but no one's letting them, So yeah, it makes a lot of sense that this is happening. Another thing I do want to return to that viability conversation, although I loved your point about how there are many different reasons. Like the ones that seem to come up in the news are like fetal anomalies, like anencephaly, no brain, or something else horrific, or the water breaking too early, or something like that. But that doesn't need to be a reason. It can just be life circumstances, like you were saying. I feel like, was it ProPublica that covered, I don't know if you read this article, that was a very good piece written, I believe it was ProPublica, covering a very, a white family in the South, I forget which state, which they had one child who was kind of ill anyway, required a lot of medical care, and she had an unintended pregnancy. And they followed this woman throughout her pregnancy, and it basically ruined her life. I mean, their family fell apart. They lost their employment. I mean, they couldn't handle it. They couldn't even economically, financially handle another pregnancy.
Yeah. And this person knew that she couldn't be pregnant at that time. And this is what happens when we deny people abortions. Like patients know best what they need for their lives. And if we don't trust people to make those decisions, then we end up with really destructive things happening. I mean, I don't know if you're familiar with the Turnaway study, but the Turnaway study was done on two populations of people. One population of people was people who were able to get the abortions that they needed, and they were close to the limits, the gestational limits in their states. It was done in a number of different states. And then they looked at also a group of people who were denied the abortions that they needed. And they matched those two groups, which is the appropriate control group, right? So a lot of studies about abortion used to look at people who had abortions versus people who continued the pregnancies, but didn't look at like people who were denied abortions. So like it wasn't a proper control group. This was the perfect match because they looked at the things like economic well-being, overall health of their other children, educational attainment, relationship status, and they followed these people for 5 years. And what they found was if you were denied an abortion that you determined that you needed, then you ended up poorer, you ended up in worse health, your other kids didn't do as well, you didn't get through school, you ended up staying in abusive relationships. I mean, all the things that like, would happen, like that this is going to be the case. And patients know that. They know their lives the best. Experts on their own lives, but it really set out like this wonderful design to show how harmful it is to be denied an abortion. And I think, we see this every day, and like one of the other big reasons that people end up later in pregnancy, who we see, are people who've been trying to have an abortion for months. So they they found out they were pregnant at 10 weeks, maybe, which is a perfectly normal time to find out you're pregnant. And then they couldn't get an abortion in their home state. So now they have to go someplace else. And now they have to come up with money. Okay, great. They get some money and then they go to the next state over where they can be seen and they're too far to be seen in that state. And now they've got to get a plane ticket or a bus ticket. They can't drive there anymore. And now they've got to get 2 or 3 days off of work or 4 or 5 instead of just 1. And they've got to get childcare. 60% of people who have abortions are already parents. And so they know what goes into having another baby, right? Like they know that it's going to be a lot of work and a lot of money and time, and they're best positioned to make that decision, I think. And so we see people sometimes literally trying for months to have an abortion. And fortunately, they're able to see us and they were able to access funding and travel support and lodging and things like that. And there's wonderful organizations like the Bridget Alliance that helps people get to their appointments. But it's really sad because it didn't have to be this way. And like these are problems that we have created as a society.
I do like that more women are coming out and sharing their abortion stories. I would love to see more men doing that as well, you know?
Yeah, definitely. And nobody should have to tell their story. Like we should be granted basic human rights without having to bare our souls. But I do think that, you know, men acknowledging how abortion has benefited them, you know, allowed them to finish their education, allowed them to parent the children they already have, like all of these same things that, you know, pregnant folks benefit from. Like, I think that men should be talking more about this, definitely.
Yes. So would you like to return to the viability topic? I think you wanted to make some, to clarify a little bit.
Yeah. So viability is, you know, I think we hear people talk about viability as if it's a date in a pregnancy. So like, oh, at this many number of weeks, 22 or 23 or 24 weeks, the pregnancy is viable. But we don't actually know if any pregnancy is viable until it's viable. Does that make sense? I mean, like I can't say if a pregnancy is viable until you have a living infant. We can estimate for an average pregnancy when it might, you know, it has likelihood to survive outside of the pregnant person's body, but that's also with fairly heroic medical interventions. And like they're standard for folks that, you know, deliver prematurely and want resuscitation. These are things that we routinely offer, but like it's not like without major intervention. And sometimes those babies, when they're born, may survive, but not without really significant impact on their future health. You know, we don't talk about that a lot. And I think that we should probably be talking more about this, not from the perspective of like, you know, we shouldn't offer resuscitation to people. I think that that's all part of reproductive justice, is these decisions being made by the people who are most impacted by the decisions, right? Like I think we should be talking about resuscitation with preemie, you know, deliveries, because that's something we can do and we should give people the option, but we should never force anybody, and certainly never force anybody to stay pregnant beyond a point where they decide they can't be or they don't want to be. But I think the idea that viability is something that a legislator could use is the problem. So viability is a medical determination. It's related only to that pregnancy, right? Like, and I can't compare two pregnancies and say the viability is the same for both of them. And it's a dynamic determination that can change, you know, hour to hour, depending on the clinical circumstances. And the last thing that you want in a law is something that is that, you know, unsure and uncertain. We don't legislate medical decisions because they're complex and nuanced. And the people legislating are not the people with the expertise generally to be able to help make those determinations with their patients. So I think that it's the question of, when do you want the government taking over your medical decisions? And the answer is never. And then also, like, this isn't, uncertain concepts don't belong in the law. Like, this is where they should be. We should be allowing and encouraging medical decisions to be made at the point of care between patients and clinical providers.
That's such a good point. You know, this is the first time it's occurred to me, like, yeah, we're increasing not only just births, but preterm births, which can come with a lot of complications, a lot of care required for the babies. Sometimes they don't make it. So that is a really interesting, good point. And yes, I mean, we see how, I'm sorry, frankly, dumb legislators can be. And it's really odd to me, you know, that we are putting these kinds of decisions in their hands and they're legislating against doctors. You know, that reminds me of that Caitlin Bernard. Well, that was Dr. Bernard was sanctioned by her state medical society for just speaking being an advocate and just speaking not revealing the patient's identity, but basically just saying that she had to provide an abortion for a 10-year-old. And that's scary, just that the law could go after you for not doing anything wrong. They can just decide, well, we don't like this messaging that you're giving out, to the public. And so we're going to come after you, going to take your license away or your ability to practice. So it is an intimidation tactic, isn't it?
Yeah. Yeah. I mean, and I think folks like Dr. Bernard who did something, she would say, I think it's all in a day's work to provide care for a 10-year-old who was sexually assaulted. And I've provided care for very young people who were pregnant as the result of assault. And it's devastating and awful. And also morally and ethically deeply right. This is something that, 10-year-old who told you, I don't want to be a mom, knows that they don't want to be a mom. And this is something that I think I can't imagine living in a society where a raped 10-year-old could not get an abortion. It just is mind blowing. My own child is, is school aged, elementary school aged. And the thought of her having to go through something like that is heartbreaking and terrifying. Mm-hmm. But I think, this idea, they came after her because she's providing abortion care and she is not silent about it.
Right.
I think they had
nothing wrong.
Moment. Yeah, she has been targeted for being an abortion care provider for a long time. It was a really, really vicious attack. And I think a lot of us who provide abortions are, we've been targeted in various ways. My own child's picture showed up on an anti-abortion website when I was in fellowship. Yeah, it's these are not.
I'm so sorry. That's horrible.
Yeah, these are people who will go to great lengths to try to intimidate folks from providing this care. And so, in that light, especially looking at people like Dr. Bernard, who were not afraid to talk about the work that they did and it's moral and ethical, rightness, that's especially infuriating to anti-abortion terrorists, that people could stand on that high ground and say, this was the right thing to do.
It's so disgusting. It's so unchristian to put your child on their website. It's so, yes. And there is nothing wrong. In fact, it is right to spread the word that a 10-year-old was raped and needed an abortion, because it will tell the public. It does change public sentiment. Public sentiment is going to, and they know that it is going to be, oh yeah, we should allow abortion, So yes, they know exactly what they're doing. And I do think it's a very powerful minority, isn't it? And I just think there's so many moves. I mean, even just the fact that there's hospitals that are Catholic hospitals bothers me. There just needs to be more separation of church and state in this country. Really bothers me. So, Diane, we are running out of time. I could keep talking to you. Thank you so much.
Imagine.
Yes. So, I guess something I want to close on is just what we can do. I really feel now it's so important for us all to remember why we are in this position. Okay. A certain president installed some really terrible justices, and every time they are just bringing so many cases to the Supreme Court now. So we are constantly under threat. And I just want everyone to remember that. And I know that none of the candidates are particularly appealing, but I really think everyone needs to vote. Yes, no one's a perfect candidate, but there is a better candidate that is going to put us on a better road to not further, reversing, going back in time in as far as women's rights are concerned. So anyway.
Yeah. I think there's a couple of things. Yeah, sure. I think remembering that most politics and most policy happens at the state and local level. So it's important to come and vote for the presidential candidate who will not continue to appoint fascist judges to high courts. That would be lovely, because that does make a difference. But the courts were never going to save us. We knew that if the balance of power changed, that these rights would be viewed in a completely different way. So I think being involved in your state and local level. Some of the ordinances in Texas that are the worst are the local ones where they're trying to ban people from traveling on highways in these counties and like declaring these cities abortion sanctuaries. Who you elect to the school board matters. Who you elect to the city council matters. Who you elect to your state legislature really matters now, because the Republicans have talked about, we want to turn this back to the states. And they don't want that. They want a federal ban, let's be clear. But for right now, the states do get to decide to some degree what their abortion policy is going to be. So state legislative elections hugely matter. And I realize that the people in power have really gerrymandered these districts and also engaged in voter suppression and loss of voting rights, and all of that is happening. People still need to turn up and vote. And I think there are really good examples of places where, Wisconsin, for example, elected a liberal judge to their Supreme Court, which I just don't think would have happened 5 years ago. People are really mad about what's going on. Loss of rights, and they're really seeing now oh shit, this is going to be a big deal. And so I think there's some momentum, and don't just focus your momentum on federal elections, because local elections really matter. I think the other thing is, a lot of people want to help, I think, with they want to volunteer, they want to, and that's all very good. What abortion seekers need is money. And I know we don't like to talk about money, but the place to give money are to your local abortion funds. And so you can find those online. They put money in the hands of people who need abortions. And so abortions need to be paid for, because a lot of insurance doesn't pay for abortions. Most places don't have insurance that covers abortions. People need hotels and gas and food and childcare. And the money you give to these local organizations stays in the community. It helps people directly with really low overhead. So a lot of these organizations are running on a small staff or volunteer staff. Please give money to local funds, because that is the highest yield for the money that you have. National organizations get a lot of grants and big donations and things like that. Your local abortion fund might not. And there are times when the funds we work with 40 different abortion funds to help patients get to us. There are times when the funds have to shut their phone lines down in the middle of the month because they run out of funds. So if you have money, you want to give money, that is the place to give it.
Okay, thank you. That is excellent advice. And your clinic takes donations. Do you have, if in case somebody wants to visit your website?
We do, and we also work very closely with organizations like Baltimore Abortion Fund and DC Abortion Fund, who help folks from all over the country. So not just people in our region come to us. I also mentioned the Bridget Alliance, which is a group that does all practical support for people seeking abortion. So lodging, travel for their companion who's coming with them, all sorts of really great practical needs. And so does Midwest Access Coalition. They also help people get later abortions. So those are all really great places that do really good work with the money that they get.
Wonderful. Can you please share where my audience can find you if they'd like to follow your thoughts?
Yeah, so I'm on Twitter. I'm at GYN and Tonic on Twitter. Our website is partnersclinic.com, and that's got our information about the clinic and also the scheduling line and all of that good stuff. Those are probably the best places to find us.
I just love that Twitter handle. It's wonderful. Okay, I'm going to leave with my closing thought, which I always do. So the patriarchy considers women subhuman, chattel, kind of use as mere vessels for their fertility aims. But in the Gynarchy, we know that women should be treated like the human beings that they are, and that they have the right to govern their bodies and decide how to use their bodies, what to do with their bodies, when and if to have children. So down with the patriarchy, up with the Gynarchy. Thank you so much for joining me, Diane.
You're so welcome.
Did you enjoy this episode of the Gynarchy Podcast? Know someone else that might enjoy this conversation? Make sure to subscribe and share the show with your friends and family. Find us on Apple, Spotify, YouTube, and just about anywhere you find podcasts. On social media, we can be found on Twitter, Instagram, and TikTok at The Gynarchy. Thank you so much for listening.